Okay, we're just going to do a couple things here as we're about to get started. I want to salute several of you who I know were here the entire time. Who's here? If you were here the entire time, raise your hand. A lot of show-offs. No, thank you. Look, it's a lot. I think we did like 18 sessions, something like that. It's tremendous, and I know it gets long. But you know what? Every one of these things here were designed in a way to help people bring up issues, talk about things that doesn't get enough attention. So thank you very much for everyone who made it all the way through. And look, those of you who just decided to come, is this your first session? Raise your hand. Arvind, you right there, first session? No, I saw you falling asleep before. You sure? No, look, thank you so much, everybody. Look, the reality of it is it's a long 2 days. Our event in years past was 3 days. Post-pandemic, we've had to alter a couple things, and that's okay. The goal is always going to be, my promise has been that there will be a disability and mental health event every year that I'm in office. And thanks to you and our hosts like at Bethel and my friends who are joining us today, we're going to keep that promise and continue to push and to work to create opportunity and independence, greater independence for everybody. It's also amazing that we've gone this far, day and a half, and I haven't fallen off this thing. Yeah. Emily can catch me. She's been working out. I'm lighter, I hear. So, look, so we have a legislative panel. So the format here, if you missed our panel yesterday, is we have some great people who are going to, oh, hi, Deputy Secretary. Yes, hello. Great people who are going to give us some information. We're going to rely on their expertise. We have two topics that are here this afternoon. One is on mental health staffing. The other one is on the behavioral health needs of people who are incarcerated. So we're going to be doing two different panels on two different topics. This is a legislative panel, which means it is also recorded. So Abigail, watch your language. Yeah. She's not the one we have to worry about, right, Ariane? So it is an official panel, so we will do our best there to keep everything moving in accordance. My friends have come from all over the county, some from across the state. I hear New Jersey. And so we are very honored to have them. So I'm going to ask them to just introduce themselves and to let you know where they represent. We're going to start to my left, stage right. Yes. Lindsay, please.
All right. Good morning, everyone. I'm State Representative Lindsay Powell, House District 21, which includes Lawrenceville, Strip District, Troy Hill, Spring Garden, Spring Hill, Shaler, Millville, Etna, and Reserve Township. Thank you so much for having me.
Good afternoon. State Representative Dan Deasy from the 27th Legislative District, right up the street. Actually, I have Scott Township here. Green Tree, Crafton, Ingram, Thornburg, Roslyn Farms, Heidelberg, and the City of Pittsburgh. Thanks for having us.
Abigail Salisbury, I have District 34. I have part of Point Breeze, part of Homewood. I have Braddock, North Braddock, Braddock Hills, Churchill, Chalfont, Edgewood, East Pittsburgh, Forest Hills, Rankin, Swissvale, Wilkins, and Wilkinsburg.
Hi, folks. State Representative Jessica Benham, the 36th Legislative District. I have much of South Pittsburgh, Brentwood Borough, and Mount Oliver Borough. My list is easier than Rep. Salisbury's, and very excited to be here for a second day in a row to continue to delve more into disability-related issues.
Hello, everyone. My name is Arvind Venkat. I'm the state representative in the 30th Legislative District in the North Hills, which encompasses part of Hampton Township and then all of McCandless, Franklin Park, Ohio Township, Kilbuck, Emsworth, Ben Avon, and Ben Avon Heights.
Hi, I'm State Representative Emily Kincaid. I only have 5 municipalities, so it's not going to be quite the list. I represent parts of the north side of Pittsburgh, North Hills, Ross Township, Bellevue, Avalon, Westview. And I'm going to kick it back to Representative Mercuri, who came in when we started.
Thank you, Emily. I appreciate that. It was good teamwork. Representative Rob Mercuri, state rep in the 28th District, which is the North Hills area that includes Marshall Township, Bradford, Woodsboro, so half of North Allegheny, which I share with Rep. Venkat, and then Hampton I also share with him. Then I have West Deer Township, which is part of Deer Lakes, and Pine and Richland.
Thank you, Rob. All the way down to my right. Give him a mic, Wayne.
Right.
Come on, help. Wayne wants the mic.
Brian Markosik, 25th District, the far eastern towns in the county here.
Thank you. And last but certainly not least, Mandy. Did you guys jump around? All right, I apologize.
It must be
I
a
thought
long-
this would go quicker.
Must be a long day for Dan, huh?
All right, I skipped it. Sorry, Wayne. Hit it. My fault.
okay. I'm Wayne Fontana. I'm the state senator for the 42nd District, which includes Scott. I have a lot of municipalities and neighborhoods throughout the area. It's great to be here again. We need more progress in this area, though. I know that. I've been here a bunch of years, and we'll keep fighting the fight. Thank you.
I'm Joe Hohenstein. I'm from a small town out in the southeast Pennsylvania called Philadelphia. And the residents of my district in the 177th have actually petitioned to be the 22nd county in New Jersey. So I don't know if you'll see me here next year.
Good afternoon, Ariane Abney. I represent the 19th Legislative District, which is in the city of Pittsburgh.
Okay. All right. Look, I thank Mandy. Okay.
Hi, Mandy Steele. I'm the 33rd District. That's Sharpsburg, straight up the river all the way to Natrona Heights. And I'm so glad to be here.
Anything else you want to tell us about your district?
The demographics are...
So, look, I want to thank all my friends. They've all made an effort here with it. I want to be honest, when we first scheduled this event, we actually thought the primary would be moved. Well, the joke was on all of us. It seemed the primary isn't moved. All my friends have made a lot of sacrifices to be here during a crazy week of both in session and with a primary. So I want to thank everybody. And I also want to thank Rob McCurry, because Rob was the only Republican who showed up to be on our panel. So I want to say thank you, Rob. And I will acknowledge that Senator Robinson did an event which I appreciated as well. Look, the best thing, as we talked about earlier, was disability and mental health is strongest and advancing further when there are no labels that are attached. I have no doubt that my friends in my caucus I very much appreciate, and Wayne's caucus appreciate leading. We do need people like Rob who care, which I very much thank him for doing it. Rob, I think you've been here ever since you've been in office. I appreciate that very much. We need to see bipartisan efforts to advance bills that make things work. And as much as my caucus, with bills I know that Rep. Benham recently did, and I know some others as well, recently got done, we still need our friends on the other side to get them through the Senate and to the governor. So that being said, thank you everybody for joining us. The panel has been patiently waiting. I was sort of not paying attention, and we're going to move right in. And we are joined first, and let me do a brief introduction, with Jennifer Smith, who's been here before. I forget how many times. 3?
Something.
Yeah, right here.
What can I?
That's why we bring them. No, obviously we hope that it's not anything serious. But we're very glad that Dr. Venkit is here. So, yeah, God bless. Hopefully it's nothing big. Jen, how many years have you been here?
I don't know. A few.
3. So obviously, Jennifer Smith is our Deputy Secretary, Pennsylvania's Office of Mental Health and Substance Abuse Services in the Department of Human Services. She previously served as Secretary for Department of Drug and Alcohol Programs. In her career in behavioral health, she's prioritized improving access and enhancing quality of services, as well as fostering collaboration across the system. So we very much appreciate Jen. When I gave her a call, she's like, I'm in. It was very quick and easy, which I appreciate. Thank you so much. Sitting right next to her right is Dr. Michelle Shine. Dr. Shine is from the University of Pittsburgh. She's Program Director and Clinical Placement Coordinator for the Clinical Mental Health Counseling Program. She is an Associate Professor at Pitt and Vice Chair for Education in the Department of Counseling and Behavior Health. So I want to thank you both. We are going to be getting into the topic of a mental health staffing 101, building the needs of tomorrow, and we very much look forward to your testimony here today. So, Jen.
Sounds good.
Deputy Secretary.
I'll kick us off. All right. Thank you so much, Representative Miller. We appreciate that you do this event and that you care so much. And a special thanks to your colleagues who agreed to join. Quite a turnout. Thanks to you for really devoting time and attention to the issue. So the other two individuals on this particular part of the panel are really the experts that I want you to hear from in terms of the specific workforce challenges. So I'm going to do just sort of a bit of a tee up for the two of them by giving a landscape of the behavioral health system here in Pennsylvania, just to kind of level set for everybody about when we say behavioral health, what does that mean and how does mental health kind of fit into that system? And I'll talk just very briefly about some challenges around the funding of that system, which contribute greatly to what you're going to hear from the other panelists. So I'll be quick, I promise. All right, so in terms of the behavioral health system, there are really two agencies in the state of Pennsylvania that are the biggest players in terms of driving programming and funding around behavioral health. And those are the Department of Human Services, and that is the agency that I am a part of, and then the Department of Drug and Alcohol Programs. And the Department of Drug and Alcohol Programs has oversight of drug and alcohol programming and funding. The Department of Human Services oversees the mental health system and its programming and funding. And the Department of Human Services also administers the Medicaid program, which of course crosses both the mental health system and the substance use disorder system. So in my role as deputy for the Office of Mental Health and Substance Abuse Services, I am responsible for all of the mental health programming that happens at the county level and the funding that is allocated to them for that purpose. I also oversee our 6 state mental hospitals as well as 1 long-term restoration center. And then I also have oversight of the Medicaid program as it relates to all of behavioral health, so both mental health and substance use disorder. So it's really our two agencies working in combination with one another that impacts the behavioral health system more broadly across Pennsylvania. And the next point I'm going to make is definitely not going to be lost on any of my legislative friends here. But we live in a commonwealth. And as such, that means we are a very decentralized state in lots of ways. And that is no exception for behavioral health. So what I mean is the counties have a tremendous amount of authority in terms of determining the programming and the spend of the funding that comes to them to support their specific county needs. And there are lots of benefits to having a decentralized system. There are also some challenges that come with having a decentralized system, especially with such disparate counties. You know, we have some that are very, very small and more rural. We have some that are much, much larger. The demographics, which I'm sure you could tell us all about, vary greatly across all 67 of those counties. So it's important to remember when we're talking about the behavioral health system, of which mental health is, you know, one component of, that a lot of the programming and funding is really being driven out at the local level. So there's a lot of authority at the county level to determine the most appropriate spend for those dollars. So I wanted to make sure that that was kind of really clear for folks. And that leads me to a really quick 101 about the types of funding that support the behavioral health system. And the list is very long, which in some ways could be considered good in that we've got lots of sources contributing to the funding, but it's also very complicated in that each of these different funding sources that I will mention has its own requirements, parameters, timeframes, reporting requirements. And so when you're trying to pull all these different funding sources together to use them for one purpose, it gets kind of administratively burdensome for both the counties and for the state. So quickly, I'm going to run through them. We've, of course, got private insurers that help fund the behavioral health system. Don't want to lose that point. Aside from that, there is the federal Medicaid program. There's the federal Medicare program. There are federal block grants that flow through the Federal Department of Health and Human Services. Those come to both DDAP and Department of Human Services for mental health and substance use disorder. There are separate federal discretionary grants, and I am not going to list all of those for you. Those are kind of unique purpose grants. There are some around suicide prevention, around homelessness, around opioid response. List goes on and on and on. And each one of those grants has its own time frame, requirements, eligibility, reporting requirements. Then we have the state medical assistance program, so funds that the state contributes toward individuals on medical assistance. We have state appropriated dollars, which all of you contribute to, and that happens both in the mental health system and in substance use disorder. And then there are county dollars. So there are dollars that the counties actually put toward these services as well. And that is not a comprehensive list. That's probably just the list that encompasses the largest majority, excuse me, of funding sources. So you can see it's a very complicated manner in which we cobble together funding in order to support the needs, behavioral health needs of Pennsylvanians. I want to really quickly shift into talking about the goals for our office as it relates specifically to mental health. So there are really 3 goals that we have in the Shapiro administration, and the first is to build collaboration. And when I say collaboration, I mean within the Department of Human Services, because we are such a large agency and we need to work really closely with the Office of Developmental Programs, with the Office of Medical Assistance, Long-Term Living, list goes on, but also across state government agencies. So I opened with explaining that there are 2 state agencies that really work together to oversee the behavioral health system. So it's really important that DHS and DDAP work closely together and talk about what their funding priorities are, what their policy decisions are, and how we can bring those 2 systems closer together. But I also mean collaboration with our stakeholders. And stakeholders is a very broad term that certainly could encompass legislators, it could encompass providers, and perhaps most importantly, it includes consumers. So individuals who participate in and receive services through the behavioral health system. So we really want to make sure that every policy decision that we're making, and when we're looking at all these funding options and how do we pull things together, that at the center of all those conversations are the people who are receiving the services. And how do we try to build a system that best delivers the services, even when that means creating administrative burdens for the state or for the county to pull all the right things together to make that happen more seamlessly for the consumers. So collaboration was the first. The second goal is expanding access and building capacity. And so that's a lot of what you're going to hear some of the other panelists talking about today in terms of challenges with workforce, and the ability to expand access and build capacity is extremely limited right now. Many providers are struggling even to operate at their current capacity. In fact, very few of them are operating at their capacity. And that is not because there's not a need for the services, it's because they don't have the appropriate staff to be able to operate at that level. So you're going to hear more about that. And then the third goal is modernization. And when I say modernization, I do incorporate IT modernization into that. That's the thing that most people jump to when they hear modernization. We are implementing electronic health records in our state hospitals right now. So that will be an amazing accomplishment for us to finally get away from paper record keeping in our hospitals. That will be great. But aside from that, modernization also includes taking a look at our policies and our regulations and accounting for the current state of our environment and the needs for behavioral health services. We have regulations that are very outdated. In some cases, we don't even have promulgated regulations in a certain area where we should. And so really needing to take a look at post-pandemic, what has changed since these have been in place, and how do we work really carefully with other state regulatory bodies to ensure some consistency with those regulations. Because the more consistent we can be, the less the administrative burden on the providers, which allows providers to spend more time and resources on their workforce. So it's kind of very directly related to the topic today. And then I'm almost done here. I do want to call attention to the fact that I know Governor Shapiro was here yesterday. I'm sorry that I missed him. But he has committed to proposing some pretty significant funding for the mental health system in his 24-25 budget. I'm not going to read all of those to you. I think you're probably familiar with them anyway, but one that will have probably the biggest impact is an increase to the county base dollars. So these funds are state appropriated dollars that come with really no restrictions. So, you know, a lot of the federal funds we get, you can't use for certain purposes, like you couldn't use it to build a building. State dollars you can. And so counties have the most flexibility with these funds, and they're using them to fund services for under and uninsured individuals. And as we hear from counties, the number of those individuals and the cost of the services that they are seeking continues to climb. So really important that we dedicate some funding to increasing the resources that counties have available to them. And then the last point that I'll make, and I usually start with this one, but today I decided to end with it, is that today I'm sitting before you not just as a deputy secretary and a policymaker, but also as a consumer of these services. So I am the mother of a total of 8 children that range in age from 6 months to 25. Many of them have been consumers of mental health services at some point in their lives, but I also have a teenage daughter who has an intellectual disability, and I have an adolescent son who is autistic and has ADHD. And so I am all too familiar with this system from both the funding and policy-making perspective, but also being a consumer and being one of the people on a wait list desperately trying to get services for my children. So, you know, I am extremely familiar with all the challenges that we're talking about, and I just very much appreciate that we're spending the time to talk about them, and that, you know, we can really have these good dialogues about where we can invest more in our system and how we can support the people who desperately need the services. And workforce is a huge piece of that puzzle.
Thank you. Dr. Shine?
Thank you. So first, let me start by saying I was asked to talk today about what it takes to become a mental health professional. I'm coming at this as a licensed professional counselor and a certified rehabilitation counselor, but I would like to talk about all master's level clinicians. And so when I say that, I mean specifically licensed professional counselors, licensed clinical social workers, and licensed marriage and family therapists. As you know, the mental health crisis is a national emergency, and according to the data from the Kaiser Family Foundation, in 2022, 47% of the US population was living in an area with a mental health workforce shortage. They further reported that some states required up to 700 practitioners to remove this designation. The reasons underlying this shortage are complex. Expanding the mental health workforce requires a comprehensive and collaborative effort involving policymakers, educational institutions, professional associations, healthcare organizations, and the community. And I hope that I can shed some light on the needs of mental health trainees. In order to become a mental health clinician at the master's level, students must complete a minimum of a 60-credit master's degree. During these degrees, students participate in field experiences that allow for the translation of theory to practice. In Pennsylvania, once students graduate, they then begin their licensure process. The social work profession has had an associate license that offers protection and benefits for students and trainees as they work toward their clinical license. Until just a few weeks ago, licensed professional counselors and marriage and family therapists did not have that. But I'm thrilled to say that as of April, we can now have an associate license that provides some protections for our recent graduates. Because of not having that license, it severely limited where our students could go post-graduation. However, during the licensure process, all mental health professionals must pass a credentialing exam and then spend 2 years of supervised clinical practice that equates to about 3,000 hours. While each of these professions has a unique degree with their own accrediting bodies, scopes of practices, professional organizations, I would like to stress that they are all well qualified and equally qualified to provide mental health services to consumers. It is my hope that stressing that backing one profession alone will not solve the mental health crisis. Most programs at the educational level are limited with the number of students they can take, generally because of the faculty to student ratio. And so the more funding that can go into training programs, the more students we can accept into those programs. According to the American Counseling Association, they highlighted 5 key reasons for the shortages of mental health therapists. These included lack of funding, poor reimbursement rates, low retention, an increased need for services with limited access to care, and an aging workforce. The things that affect my students the most and the students graduating from mental health programs is really funding and reimbursement and low retention. There are several challenges with funding for mental health therapists, but the one most striking is really the reimbursement. We need support from people who stand up for mental health care and introduce legislation that mandates fair and equitable reimbursement for all mental health services. Failing to do so will fail to prioritize the well-being of the people in our community. From a funding standpoint, it's clear there's a need for mental health therapists. Unfortunately, agencies, as Jen noted, are facing limitations in the ability to hire clinicians, and current staff are being asked to do more with less. This contributes to the burnout for qualified folks leaving the field, which then leads to the inability to take students to train them in these positions. And while many of the concerns that are going to be noted in just a few minutes are true for providers, they will also be true for mental health grad students. For reimbursement, private insurance companies set the standard for how much a session can provide to a therapist. As of January 2024, the reimbursement rates for a 60-minute clinical session ranged anywhere from $100 to $150. Insurance companies have been pushing back on providers funding for the 60-minute session and have seen an increase in the companies denying that, opting to approve only a 45-minute session, which cuts funding for a mental health therapist to about $75. Further noting that is the Bureau for Labor Statistics noted that the 2023 median salary for most mental health therapists ranged about $56,000. In Pennsylvania, the rates for that is just slightly higher. Another funding and reimbursement issue stems around the issues for Medicare and Medicaid. Until January 2024, both counselors and marriage and family therapists could not accept Medicare, which left a large gap for this specific group of people. While the applications are open for counselors and marriage and family therapists to apply to become credentialed with Medicare, the system is not yet fully operational, leaving therapists struggling to get approval to accept this vital source. As with many fields, few private practices and private practitioners accept Medicaid, which leaves a very vulnerable population with severe limited access to care. As for low retention, the mental health field in general would benefit from additional support, but our recent graduates face additional hurdles. With the increase in college tuition and the associated fees, students are leaving college with increased debt. Pay rates have not yet caught up. As unlicensed clinicians, new grads often face low compensation with fewer benefits associated then with a rising cost of living in most of the country. The other big piece that I would like to stress and spend a few minutes talking about is the fact that all mental health clinicians at all master's level must complete a field placement. These field placements are required as part of accreditation and licensure, but they put students at a disadvantage. Given the intensity and the duration of educational programs and these clinical placements, it's not feasible for most interns to work for money while they complete the requisite field placements. Additionally, most of these field placements are unpaid. Students often grapple with delaying this pivotal part of their education while they work to save money to afford tuition and then the subsequent loss of income. Most recently, we just received satisfaction survey results for our program highlighting this point, and one of our students who is about to graduate next Saturday highlighted their biggest complaint is the lack of affordability across the board to get through this program. Working so intensely at an internship placement without pay was a stressful experience, and my limited ability to work outside of this being a full-time student and part-time employee added to this. An alternative is that students then opt to take out increased student loans to live off of. Scholarships and paid internships would immensely lighten the burden for our students. Once students graduate, support to repay these loans would also be great. Some of our students are graduating with upwards of $100,000 and yet only making somewhere between $47,000 and $56,000. The mental health and well-being of recent grads is also low, with people burning out soon after graduation and possibly leaving the field before they even obtain licensure. In addition to graduating with increased debt, new grads must incur costly licensing and credentialing fees, mostly their certification and licensure exam and the continuation fees. In private practice, insurance reimbursement is tied to licensure, so until clinicians are licensed, they face hurdles in working in these settings. A substantial portion of unlicensed or pre-licensed clinicians complete their clinical hours at community-based mental health agencies. Folks often stay for 2 years, obtain their clinical license, and then leave for private practice where they can make more money, which then leaves the community-based mental health agencies with another open cycle and perpetuating the cycle for the needing to replace employees. And unfortunately, as many of you know, rural Pennsylvanians are even worse off. There are 18 counties currently in Pennsylvania as designated that the entire county is experiencing a mental health shortage, and 1 county is partially experiencing a shortage. And most of these counties are in the non-metropolitan areas. Tied to field placement experiences is the requirement for the on-site supervisors during these placements. With staffing shortages, the number of clinicians that can then take and properly staff an intern also decreases. Without internships, students can't graduate from their program, continuing the staffing shortages in this field. While paid internships for students would be a win, supporting sites and supervisors to take on mental health students would also be an important step in supporting the pipeline. I will end with my licensure challenges. The primary challenge that we face as mental health therapists is licensure. There are many restrictions that come with licensure, as each state has their own specific requirements for licensure. As a provider in Pittsburgh, we are in close proximity to West Virginia and Ohio, but in order for me to see clients in either of those states, I would also need to obtain licensure in Ohio and in West Virginia. While teletherapy has helped, Pennsylvania residents cannot see a provider who does not hold a license in Pennsylvania. Licensure portability is a way to combat that, but greater support is needed, and we could learn a lot from psychology. In psychology, 42 states have enacted portability or compact laws, Pennsylvania included. While licensed marriage and family therapists are not pursuing portability, counseling and social work efforts are already underway. Unfortunately for social work, only 7 states have enacted legislation supporting the social work compact, and 20 are pending, and I know Pennsylvania is one of those states. For counselors, 30 states have enacted the license compact. However, Pennsylvania efforts have stalled. To sum this up, I would like to talk about some supportive legislative options that might be able to support our students. And I'd like to focus for students on the areas of scholarship and tuition assistance and possible paid internships. And for graduates in the areas of loan forgiveness, ways to support licensure and certification, such as decreased fees, low-cost training to maintain certification and licensure, the licensure compact, better and more consistent reimbursement for counseling services, and other incentives to stay in the field. The key points that I'd like to end with echo the sentiments from the 2020 Pennsylvania Mental Health Workforce Shortage, the Challenge and Solutions Staff Study, which includes increased funding and availability of tuition repayment programs and the limiting of increases in tuition at Pennsylvania state systems of higher eds, and encouraging educational institutions to recruit students from communities that are underserved. And with that, I would like to end by acknowledging Representative Hauer, who I know is not here, for their efforts in supporting legislation for social work students by proposing House Bill 1349 and 1350. And I would also like to acknowledge Representative Abney for his efforts in House Bill 1481, which is the licensed clinical social work's efforts to join the Social Work Compact. It is my hope that future discussions will also include licensed professional counselors and licensed marriage and family therapists in these efforts. And to all the Pennsylvania legislators, fellow panelists, attendees, thank you for your time and interest in supporting mental health access for all Pennsylvanians.
Thank you. And before we move to our next speaker, let's pause for questions, obviously. A bunch of people got some shout outs. It's pretty good. Senator Fontaine.
Thank you. Just to address the funding and reimbursements and that, I'm the chair of the FIA, and we have a program called PA Help, I think it is. When I read through it, it seems a little intense maybe. So I think we need your help in designing these programs. I know in the budget Governor Shapiro put an extra $5 million into in this budget proposal for that, but it's for interns, and then they get a salary for that. So, you know, if you guys look at the program and think it needs some changes or streamlined or something, please let me know. I'm happy to, you know, fight that fight, because to your point, that we know that that's high for students in Pennsylvania, and we need to try to find ways to do it. Also, it's Senate Bill 874 is out there. I'm a co-sponsor, but it's from Senator Dillon, Tartaglione, and Kane, folks from Philadelphia, believe it or not. I'm kidding. But anyway, it's a student loan forgiveness bill, and it caps it out at $6,250. So another, you know, attempt to try to, you know, hold down student debt, and specifically for the area that you're talking about. The PA Helps is for nurses, psychologists, school counselors, and social workers. So if you take a look at that, go online, take a look at that program, and see, you know, in other ways that we can help to make it work. That would be great. Thank you.
Thank you, Senator. And I want to go to Dr. Venkat. I do want to thank the good doctor, and we had another volunteer. Thank you. Thank you. And just so everybody knows, Woman's okay, and a lot of us know her. She's a great self-advocate, so thank you both for caring for her needs. Dr. Venkat.
Sure. So first of all, thank you for your testimony. I did want to bring up for you and the group that we have made some progress on the licensure issues. We did recently pass legislation, I believe Governor Shapiro has signed it, for associate licensure for counseling, so that the reimbursement issue can allow people, while they're still in that stage of their training, to receive reimbursement at their employers and the like. And on the issue of the interstate compacts, what has held that up is a dispute between Pennsylvania and the FBI on criminal background checks for healthcare professional licensees. We have finally come to a resolution on that and passed that legislation out of committee, and I imagine it will fly through the legislature. And that's what has prevented us from taking up, for example, Representative Abney's legislation on social work compact. I have ones for audiologists and speech pathologists, and so I would imagine that this will be something that is moving forward very rapidly. But thank you, and keep up the pressure on us in that regard.
You know, one of the questions that jumped to my mind was I think the compact portability is obviously has its clear advantages. By the same token, there are so many underserved in Pennsylvania now. So I'm glad. I want to talk about ways that we can help make the industry supportive and to address needs. It's fantastic for residents who live 45 minutes across from here in the West and they're in Ohio. That's great. But by the same token, it seems like the biggest question, correct me here, the biggest issue here in addressing Pennsylvania needs is more in relation to reimbursements. Am I wrong?
I think that's part of it. I think the one thing about the compact is that it would also allow licensed counselors and marriage and family therapists and social works to also provide services in Pennsylvania, since there would be that reciprocity. So at a minimum, my goal would be to have more counselors in Pennsylvania, but in the interim, if we even had people with licensures to be able to provide services. But yes, the reimbursement is challenging. You have things like Headway and Amway, which are in some of these privatized like mental health programs that are trying to take on and incentivize people to come to them, but there's little oversight and regulation on those. I know that a lot of my students, when they talk about private practice, is that it goes down to the fact that some of them are salaried, so they know that they're going to get funding and paycheck. But a lot of private practices are 1099 contractors, and so if they don't see a client, they don't get paid. And if a client no-shows, there's no way to get that. And I know that's just the private practice model, but if you're receiving $75 when you're expecting $150, that's really hard for people to plan. So I think some oversight on just better regulations on making sure that there is fair pay or fair reimbursement, I think would be helpful.
Well, let me just ask you one, and I know we have another speaker, so I want to get to her as well. But the best way to address Pennsylvanians who are not who are getting caught in reimbursement problems, for them to get treatment in Pennsylvania is what?
So you're talking about consumers that are getting stuck.
So if you're
in
a
the process?
consumer and you're like, look, my reimbursement rate is so low that it is not possible, or I'm struggling to find the practice that can pick me up because of how their economics is structured. So what is the best way for us to address those Pennsylvanians who are waiting to find that lucky combination of economic factors that allow somebody to pick them up?
Boy, that's a magic question. I wish I could answer that
That's
one,
it.
right?
That's it, right, everybody? All right, we're done.
If we knew the answer to that one, I don't know the answer to that question. But I think that what you're describing is also a contributing factor to our workforce issue, in that individuals who do work in the field are a hot commodity, right? So they are willing to move to any other provider who's willing to pay them better for the services they're offering. And that means that we're seeing people jumping all across the system. So they may not be leaving Pennsylvania. I mean, they're still offering services, but they are hopping from provider to provider, maybe changing specialties in order to get access to that ideal combination of factors that they're looking for. And every time that happens, it sort of disrupts the provider that they've left in terms of now needing to train someone else, maybe adjust shifting schedules. And sometimes one person, just one staff member leaving a provider could change their entire ability to serve the current capacity of consumers. And so that's the situation we're in. And then when you layer on top of that the intricacies of telehealth, which it could probably be its own panel discussion, that adds another kind of layer of complexity. People want to go where they could sit in their home and deliver these services instead of driving to a facility. But we have Pennsylvanians who still want in-person services in a clinic or a facility. And so we've got that challenge to navigate as well.
Thank you, and look, you're totally right, because I think we can get into the effectiveness and how of that as well. Look, I want to thank you both, and I know you next year's panel. All right, that's true. We do have one more panelist, and I'll ask you guys just to maybe hang tight in case we need you again. But our final panelist today on this topic is Gretchen Kelly. Gretchen is the Executive Director of PLEA, an affiliate of Devereaux Advanced Behavioral Health. PLEA serves children, adults, and families dealing with developmental and behavioral health challenges. She also serves as the Legislative Affairs Committee Chair for the Conference of Allegheny Providers. Gretchen, good to see you as always. So please take it away.
Thanks to my fellow panelists, Jen and Michelle. Thanks to all of you for being here, and especially the representative from New Jersey. Thank you for attending today. It's with pleasure that we continue this discussion about the workforce needs in the behavioral health realm across Pennsylvania. So just a few comments to sum up some of what you've heard my colleagues talk about today. The workforce shortage in the behavioral health field, particularly within the Medicaid framework, is multifaceted and influenced by both financial and operational challenges. The link between provider rates and the wages we as providers can afford to pay highlights a core issue in workforce recruitment and retention. Because human services are funded primarily by Medicaid, we can't raise prices like private businesses to pay higher wages to attract and retain a highly skilled workforce. You all as state lawmakers have a role to play. State budget decisions largely drive Medicaid rates, while commercial rates are shaped by the market power of health plans and fueled by consolidation and influence of private equity. This fragmented approach has led to growing rate differentials with little system-wide considerations of the implications for both access or cost. Providers relying primarily on Medicaid revenues cannot compete with the wages offered by those commercially insured patients, leading to a workforce drain. Pennsylvania has substantial rainy day funds that could be used to increase wages in the human services sector. This investment could help retain existing workers and attract new talent to the field, addressing this massive workforce challenge. Currently, there are efforts in the legislature that seek to develop more consistent processes across the behavioral health managed care organizations, specifically for substance abuse disorder centers of excellence, in an effort to create a better path forward for all licensed behavioral health services. While this is specific to those with substance abuse issues, the same changes need to be facilitated across the health choices system. Some reform could include cataloging state and federal standards and encouraging a national benchmark, advocating for simplified credentialing, consistent operating practices across all behavioral health managed care organizations for reduced administrative burden, embracing technology to replace antiquated paperwork requirements, assuring adequate reimbursement for all manner of in-network behavioral health care. Psychiatrists, for instance, lag 25 to 50% behind other medical specialties, helping insurers recruit clinicians into their networks. The current alarming statistic identified for clinicians in the behavioral health sector is that 40% of their time is spent on administrative duties. With 40% of clinicians' time spent on these duties, regulatory changes to reduce this burden could significantly impact workforce capacity in addition to job satisfaction. Reducing regulations that introduce more flexibility into how and where clinicians can operate will make the Medicaid sector more attractive and could prevent clinicians from moving to private practice. Currently, doctors, nurses, and clinicians are fleeing the Medicaid space for private practice, for better pay, and almost non-existent regulatory and administrative burdens. Addressing the projected need for more behavioral health providers involves not only improving current working conditions, but also building a stronger educational pipeline to bring new workers into the field, addressing long-term needs. According to the PA State System of Higher Education, Pennsylvania will need 12% more social service providers, including social workers, by the year 2030. This statistic, coupled with a broken workforce pipeline, will cause a far more pervasive end result for the growing number of vulnerable PA residents. Overall, a combination of reduced regulatory burden, attractive financial incentives, operational efficiencies, and strategic investments in the workforce is necessary to address the current and future challenges in the mental health profession within Pennsylvania's Medicaid system. We can do better than this. The consumers we serve deserve to not only have the best providers, but more time with the providers, and not have these skilled clinicians stuck in an office, dotting I's and crossing T's to ensure payment for Pennsylvania's most vulnerable citizens. With over $6 billion sitting in a rainy day fund, please know that for behavioral health providers, our rainy day is right now. Thank you for listening to these remarks, and please let me know if you have any questions.
Thank you. While I pause just for other questions with it, 12% more. I guess part of the question I have is, it's easy in some ways to know what we have graduated before.
Right.
And it's easy to know who's on a waiting list for like a disability service. I get a little lost with how we are projecting the mental health staffing needs. Perhaps, so I don't know if it's something you can help me with, Gretchen, but how are we able to do that without like a state waiting list or something like that helps us really know the people seeking the services?
Right, the number of people sitting on waiting lists. And actually, it's almost an impossible answer, as some of the others, as you know, as if each organization would be able to provide those statistics, it would be alarming. And I don't think that that's something that the state tracks specifically to the number. You can, yeah. So that is a really, really hard question to answer because we know that access is long. I know that one provider in particular recently shared a statistic that there were 100 children waiting on her wait list for services. And there wasn't an opportunity because of regulations. There would be opportunity to serve those children collectively in group settings and in other formats, but the regulations don't allow for that. So as those numbers are growing, some of the flexibilities that providers could be afforded just aren't there as well in order to get paid for some alternative kinds of treatments. That doesn't answer your question. Yeah.
Jen?
Please.
So I think the other kind of piece of this workforce challenge issue is something that Gretchen was touching on around, if we could relax some flexibilities from a regulatory standpoint. I think the challenge, as I have my regulator hat on right now, one of the challenges is that we have to be really careful that we're keeping in mind the health and safety of the people that we're serving. And unfortunately, while we're also seeing workforce shortages, we're also seeing an increase in serious incidents and licensing actions being taken against some of our providers, particularly those that serve children, which is very concerning. And so, we are seeing this picture from two sides. We're seeing that there's this desperate need and individuals on wait lists, while we're also seeing that some of the providers we have in Pennsylvania aren't meeting the kinds of standards we would want them to meet, and the children in their care are not receiving good quality services. And so we have to be very careful about balancing how we manipulate those levers in terms of, relaxing flexibilities so that we are not jeopardizing the health and safety of the individuals that are receiving the services. That's such a delicate balance.
Thank you. Rep. Powell?
Thank you so much for your testimony. I had a question as it pertains to workforce shortages with providers from diverse backgrounds. We know that some of our communities, in particular, our communities of color, are in desperate need of some of these providers. What has the state done, or what are some things the state could do to get more diverse providers in these spaces?
Do you want to answer that? Sorry.
I'll just keep sitting up.
Yes.
Yeah, so the diversity issue is one we see both on the workforce side and on the provider side in terms of, serving those populations. And we definitely see from a bigger behavioral health perspective, the need is greater in those minority populations. And so the challenge is trying to match where we have the services with the people who need the services. And so while we have wait lists in some areas, we've got huge capacity in other areas. And that is especially troubling for some of our minority populations who really kind of desperately need some intensive services. But the areas in which they reside are not areas that they have access to those services. And this gets to that telehealth panel that we're going to maybe have next year. In that historically, pre-pandemic, when telehealth was sort of not an option, transportation, childcare, those were extremely limiting factors for some of those vulnerable populations. I'm a single mom with 3 kids at home. I can't leave my kids home alone for me to ride a bus 15 minutes to go to my appointment for an hour and then 15 minutes back home. So some of our system has evolved to a point where I think we've opened up opportunities for some of those populations in terms of consumers being able to access services. Where we are still falling short, in my opinion, is in making the workforce look like the people we serve. And so in recruiting, and this I think is true across all of behavioral health, across the full continuum, prevention, intervention, treatment, and recovery services, we could do a much better job in terms of looking, linguistically, looking culturally and ethically at how we ensure we've got a workforce that is representative of the types of people we're serving. And that will by nature also help address some stigma issues. It will help bring populations that have historically been very hesitant to seek any kind of health care, whether that's behavioral or physical, to start coming to seek services. So I think there's probably still a lot that can be done, and those are kinds of issues we'd love to partner with you on, to talk about what are your communities seeing, how could we offer incentives for individuals that are part of those communities. Is it a financial incentive? Is it a flexibility incentive within the workplace? So I think that's a great topic for us to continue to work toward.
I'll stay right here. The other thing, we also, as a community of providers, need to do a better job of reducing barriers to. I understand that folks from minoritized identities often are have a little bit of distrustworthiness of our profession just because we have not been good to folks in the community, and so we need to do a better job of educating people about the work that we're doing also to do better. But we also need to remove barriers for folks to be able to come to training programs because, I was on a panel this morning for our graduate study committee at Pitt, and we were, with the Supreme Court decision and moving to holistic admissions, how do we make sure that students from minoritized identities still can get into Pitt or to other programs because new barriers have been created, and making sure that we can support people, not only getting them into the program, but keeping them in the program because they need faculty that look like them also.
Right, keeping them. All right, I want to thank you very much, all three of our speakers, the Deputy Secretary, Dr. Shine and Gretchen Kelly. Thank you so much.